Okay, so here we are back with Bill. I do have a lotion bottle here, but this is one of those times where you don't want to slobber up the skin and get it too slick and lubricated, because it's not going to help you in getting where you need to go. We already know that his leg is being held up off of the table. So the first thing that you should do is, now we're working through Bill's pants here, and that'll be just fine. And he's got a knee brace on, it won't be in the way. Not for most of it. And so we'll do the best we can. Now put your fingers into the IT band and to see how much tension is there. Now, interesting thing with Bill, as his leg is sitting here, I don't feel that much tension in the IT band. So if that is the case, if your fingers cannot verify what you suspected, what else could it be? Now what you have to abduct the leg is piriformis, is glute minimus, and glute medius. And so those might be more of a prime target if the IT band is not that involved, and sometimes it's the entire group and sometimes not. Your fingers have to find and feel and verify. Is there a tightness? Is there a tenderness? And so, Bill, as I push in here, is this tender at all on you?
It's a little tender.
It's a little tender, so not very much. You know, a lot of times this will make people's toes curl and make them want to get off the table and get away from you. And usually if they're going to have trigger points in the IT band, you can take a distance from the greater trochanter to the knee and come halfway back, and usually they're right up against this back wall. That'll be a real sensitive spot. And so of course his knee brace is there, and because the IT band, we may not even have to do that much work on it. I would suggest that you use a dry palm. Just put your palm flat on the material and just start doing a cross fiber type friction. And if we had access to the rest of his leg without the knee brace, we would be doing the same thing all the way down. Now, this can be very uncomfortable to people. You might have to joke and cajole your way through it, and you know, some of it, I'm not sure where people got the idea that some therapy wasn't supposed to hurt a little bit. And I figure I don't hurt anybody, but by God, I'm going to find the hurt that they came in with. You know, it was already here. I just put a finger on it, that's all. And so you try to loosen this up a little bit. Like I say, you go all the way down to the distal end if you can. And what's going to be more important on him is actually higher up, because here we've kind of discovered that the IT band did not have the tension that I suspected, because when he got on the table, I didn't know if he had a problem at all. So this is all kind of new to both of us. But I'm going to turn the table turn the camera just a little bit so that you can see what I'm going to do up here just a little bit further. Okay, now a lot of the time I'm on the front side of the body, and right where the leg fold ends, you can find the apex of the ilium is that pointed piece of your iliac crest right in the front. You find the apex of the ilium, find the greater trochanter, and so come halfway back, about halfway back. Now this is not a perfect spot, this is a starting point. This is a place where you begin. And what are you looking for? Tight, dense tissue. You're looking to press into something that makes them want to move away because of sensitivity. And so what you have here is tensor muscle. And then right underneath it, you have the anterior division of glute minimus, which, as you've heard me talk about in the slide program, has the largest pain pattern of any muscle down the leg. Usually in the lateral lower leg, it's actually very heavy, can extend to the dorsum of the foot. It can be in the calf, it can be in the lateral upper leg, it can be in the hamstring area. And so this muscle can give people an exact mimic of a true sciatica. Sciatica basically is not a diagnosis in itself. It is a descriptive phrase, which means you have pain and or numbness in the distribution of the sciatic nerve, which can be pretty close to a whole lot of things. So you find the iliac crest, you press into glute minimus at the top. As you get closer to the trochanter, You've got you've got minimus down here, medius up higher. And so press into that tissue and right through clothing. You can do an awful lot of work. If we had access to skin, I'd be doing what we call windshield wiper. But you know, camera angle and protecting people's privacy doesn't always allow us to do what we want to do. But you put your hands together and do big sweeps all across their glutes and just below the iliac crest, and clear that area as much as you can. And do that 2 or 3 or 4 times. Go away, go back to your cross fiber down on the IT band. Don't slick it all up with a lot of lotion, because you're going to slide off and you're not going to change the tissue at all. And so do it more dry, or if you've got some Prosage heat lotion, any kind of an oil that has a dryness to it, just so that you can slide a little bit on the skin but not too slippery, that'll be fine. And so go back to where you were. This back and forth way that I work on things has really shown to be helpful to me. Is any of this tender on you, Bill?
Yeah.
Okay, now we've got a tenderness, and remember that only hypertonic tissue is tender. Normal tissue does not hurt when it's pressed. You can smash it right to the bone and it does not hurt. And so he's got a tenderness in this, and that's telling you something. It's also telling the patient something. It's like, whoops, what did we put our finger on here? Maybe this really is a piece that's involved. And you remember how high up his knee was off the table. Sometimes it doesn't take that much work to actually get some distance and some length in that material. But you know what? Somebody along in your career did the same thing to you that somebody did to me. They told me about psoas, and they told me about piriformis. And I'd have to say that we are therapist hunters. We are trying to find what the person has in their tissue. You do it by hearing their clues and running that through the filters of your knowledge, and you verify it with your fingers. Do you find the density? Did you feel the hypertonicity? Did you feel the tightness that they have in the tissue that might indicate, yes, you are in the right direction? If you don't feel those things, maybe you're on the wrong spot. But a lot of people told me, you know, focusing on psoas and focusing on piriformis, they actually put me on the scent of the wrong game. And so I want for you to pay more attention to the IT band, because nobody really talks about it that much. And glute minimus, what an ugly piece of work that is. That muscle can stop people from standing up when you get up out of a chair. It doesn't want to lengthen to let your pelvis get upright, and some people are walking with their butt stuck out and their torso is forward for the first 3, 4, 5 steps, and then finally they can get upright. I was told that was psoas muscle. That's not psoas muscle. Psoas is so long and slack that it is not causing that kind of restriction. I want for you to pay more attention to the shorter fibered muscles closer to the joint. Those are the ones that distort people's posture the most. Those are the ones that increase interjoint pressure to where the cartilage is eroded. The muscles that are close to the joint, not the big prime movers. So here I've been talking and not even doing any work. So let's go back and rub. Has it hurt you as much now as it did before?
Not as bad.
Okay, so it's not as bad, which you can expect because you did a little bit of work there. And while I was talking and my hands weren't moving, we had a little bit of fluid going in and a little bit of fluid going out, and some cellular waste was eliminated so that it wasn't irritating chemoreceptors, and so all that's a good thing. Now, it doesn't seem like we've really done that much here, but most of the time as massage therapists, we have people prone and supine on the table. We work their front, we work the back, we forget they have sides. And so a lot of times we're not even paying attention to this material here, which has a huge factor in people with hip dislocation and distortion. Now, what I'm going to show you here is another important piece. You might have learned this or heard about it as being PNF stretching, proprioceptive neuromuscular facilitation stretching. Some books call it contract relax, some call it muscle energy technique. I actually don't care what you call it. It's all the same thing. And what we're taking care of and using in our favor is something called post post-isometric relaxation. When you stretch a muscle, there's a certain resistance to lengthening. Your body does not want to lengthen it because it's not sure if you're going to hurt it. It's not sure if you're going to tear it or rip it apart somehow. So the stretch reflex is there to protect us from overextending and lengthening things. So a lot of times when you're trying to stretch things, you're getting nowhere because the body is just not going to cooperate. But if you contract the muscle first, then the period of post-isometric relaxation, you can actually take advantage of it and you can lengthen it beyond where you ever could have had you not contracted it. So take a class on that subject if you can. Watch some videos on it, but I find it very helpful, especially when dealing with this subject. So we're going to do Ober's test again. Now you saw this was like minimal work. And we're going to see where the knee comes, and then we'll finish it off with some PNF stretching. So here we go again. Remember, you lift the leg, you support the ankle, but you don't hold it. Now you extend it back. Now do you see where his knee is in relation to the table? We're about this far away, and we really didn't do that much. So the difference in the angle here is actually noticeable, and it'll take a lot of strain off of his pelvis and stop some of the friction that goes on his greater trochanter, because that material, it starts more medial on the iliac crest, then rises over the trochanter and then goes more medial to its insertion. And so it wraps over that piece of bone, and that friction can get to be pretty bad. So I'm going to actually drop his ankle, and you put your palm right on the lateral side of somebody's knee, and you stabilize their hip. And Bill, I'm going to have you push into my hand with about 30% of a normal contraction. Just push my hand up, push it up, and hold. Now what we're doing, I'm holding with my body weight. We're fatiguing the muscle. We're taking advantage of it. I'm fatiguing it by making it work. And now relax it for me and let it go, let it go, let it go, let it go. Now one more time, push and hold. Fatigue it again, take what it'll give you, and then fatigue it again. Anywhere from 3 to 10 seconds, that'll usually do, and then relax and let the leg down. Now, without me holding it, do you see the difference in where his leg is now compared to when we started? He was about up here. And so that made a big difference. Now, you know when he stands up, what kind of a difference that makes in his SI joint and in his hip and in his knee. And so that's the way I work on it. Do it multiple times. Do your cross fiber, work around the hip. Do your cross fiber, work around the hip. Do some piriformis, because is that an abductor in this position? Yes. And so go ahead and work on piriformis where you know it is. If you're not sure exactly where, just work through the glute and over towards the sacrum. And if you find a tight, dense piece of material, well, you're probably in the right direction. So I hope this helps you, because it's one of the most valuable things that I've ever figured out in my career. It was my problem when I first got into this profession. Somebody fixed that pain on me, and I've not had it again in 35 years. I've actually been able to do this for people for many years. Some of them I only see them one time, 2 times maybe. And so SI pain is something that you should be able to mechanically to get rid of for these people. And who in the world is talking about the IT band? But now you heard it here first. So I hope you enjoyed the video.